Yes, sir.
Okay. Good morning. Today we are having a ward round scenario discussion on post-op chest complications. Dr. Nitesh Pradhan, who is a third year DNBC and Imar Bangar Hospital, will present. And Dr. Arko Rai, who is professor of surgery at Calcutta Medical College, will moderate the session today. So we put a scenario and then Dr. Rai will take us through the scenario. Please share. Just read up.
58-year gentleman involved in the blunt trauma abdomen underwent an emergency splenectomy. On POD1, patient having respiratory distress and hypoxemia. Patient has history of COPD. How will you proceed?
Okay. Dr. Rai. Dr. Rai, you are muted. Dr. Rai, you are not audible.
Am I audible now?
Yes, yes, yes. So that is a scenario. We can proceed from this point and then keep on discussing.
Okay, okay. So how will you proceed?
So on POD1, patient having respiratory distress and hypoxemia. So first we'll give supportive treatment with oxygen. We'll give oxygen. And sir,
For hypoxia, will give oxygen. But patient having respiratory distress following a splenectomy, the first POD, what do you think is the problem with the patient? Hypoxia is one manifestation. What is the likely problem with this patient?
Sir, likely problem, sir, post emergency splenectomy, patient might have will ask for the pain.
What I'm asking, what might be the problem? So, if patient having a respiratory distress and hypoxemia, it clearly suggests that he has got some chest complications, some pulmonary pathology in the first post-op day, and on the background of his is a known case of COPD.
First post-op day, sir, it might it is maybe due to atelectasis or it is exacerbation of COPD.
So, how are you going to proceed? You have given oxygen. Now, what is your steps for assessing the patient to diagnose what is the problem with the patient?
Sir, after stabilizing the patient, we'll ask for the history for any pre-existing lung disease and sir, history of and if it is present, then we'll ask for the treatment taken in the past, and if any previous recent history of hospitalization due to chest infection or complication, chest infection or any pre-existing lung disease.
You see, you already said that he has got COPD. So, what you like to know about the COPD?
Sir,
first is duration. How long he is having COPD? What treatment he is on? So that is important. That what is the status of COPD? What assessment has been done? And then what about this present ailment? He has got a rotary accident, and he required an emergency splenectomy.
Sir,
as the patient is having COPD, and if the patient is a known COPD case, you can have his previous investigation checked, because the FEV1 is one of the important factor which is reduced in case of COPD patients. So you can have a look at the previous pulmonary function test which has been done in case of a COPD patient suddenly. So you can assess the FEV1 and then start accordingly, because after the any emergency or any abdominal operation, that is again going to reduce by more. So that is the first assessment you have to do after clinical examination of the patient post-operative. That we're telling that post-operative atelectasis and etc., which can occur after splenectomy. So if you are one thing, you have to see the what Sarah has told, that you have to go for the history and also check the investigation. The most important investigation in this case is pulmonary function test. If it has been done earlier, which should be in case of COPD patient, and you should go for a FEV1. What is that? Accordingly, you have to check the ABG and SpO2 and then act accordingly.
Yeah. So you should keep in mind that patient undergoing a splenectomy, particularly upper abdominal surgery, are at higher risk of developing chest complications. So if I now ask at this point, what are the common chest complications which happens after upper abdominal surgery particularly? What are the different spectra of chest complications?
Patient may develop atelectasis.
So the commonest is atelectasis, particularly basal atelectasis.
Yes.
What else?
Sir, postoperative pneumonia.
Yes.
Sir, then aspiration pneumonitis,
Yes.
respiration pneumonia.
Yes.
Then sir, pulmonary edema, ARDS.
Yes.
Patient develops pneumothorax, pleural effusion.
Yes. And although not a direct pulmonary complication, it can be a situation of acute pulmonary embolism.
Yes.
Patient might have a distal thrombus, and then there may be pulmonary embolism. So these are the different spectra of pulmonary complications. And you said the commonest is atelectasis.
Yes.
So what are the background you should take care when you go for even a splenectomy in a patient like this? Is already a COPD patient, known.
Sir, smoking, then sir, then
You have reviewed the patient. Now patient has gone for surgery.
yes.
So there are some measures during surgery and after surgery which can reduce these post-op complications.
So post-op complication can be reduced post-operatively by giving oxygen support. Then sir, we can.
You see, there are some factors. There are some factors during the perioperative period which can aggravate these complications.
Sir, factors such as
Anything to do with the anesthesia?
yes, sir, factors such as general anesthesia, which general anesthesia.
You see, this sort of surgery will be done under general anesthesia.
Yes, sir.
So these patients will undergo general anesthesia, but while giving anesthesia, anesthetist has to have some measures so that the post-op complications are minimized to some extent, because there are some bearing with the anesthesia and the post-op complications. You are giving the patient muscle relaxant, so patient is paralyzed. You are giving the patient assisted ventilation.
Yes.
So while giving assisted ventilation, you should ensure that you give the patient adequate tidal volume, number one. You apply a PEEP so that there is no collapse of smaller alveoli. So the two important measures the anesthetist should take. And then another important aspect of these pulmonary complications is a judicious fluid administration in the intraoperative period. So if you give the patient more of colloid during surgery, if you give the patient more crystalloids, overhydration can cause some sort of pulmonary complication. So these are the important things the anesthetist should take care while treating a patient with emergency splenectomy, particularly on the background of patient having COPD. Okay.
Yes, sir.
And then immediate post-op. What what is the important factor in immediate post-op which leads to atelectasis? Very important for particular upper abdominal case splenectomy.
Pain control.
Yes.
Pain control.
Pain. What happens because of pain?
Sir, diaphragmatic impairment of the diaphragmatic.
Yes. So patient has got a splenectomy, upper abdominal surgery, patient being pain. So because of pain, patient takes shallow breathing. So the diaphragmatic movement is reduced. And this leads to basal atelectasis. So the very important part in the immediate post-op is, Dr. Orko, you are muted.
Oh, okay.
Yeah. You can carry on, please.
Three things you have to remember. That is, first is pain relief. Number two is early mobilization.
Yes, sir.
And number three, fluid administration should be optimum.
Yes, sir.
There is a an arbitrary one calculation that you have to keep it between plus 500 to minus 500 ml of positive balance according to the body. If I consider the body of the patient is 50 to 60 kg, that is. And these three things you have to give because you have told that it is the COPD patients. Most likely COPD patients are smokers. The smoker are the most commonly infected in having both chest infection post-operative periods because the most prone to develop chest infection in the post-operative period after abdominal surgery. And so these three things you have to consider. And later on, you can start on incentive spirometry and also the chest physiotherapy and nebulization, these things, to get the alveolar recruitment done. This is called alveolar recruitment phenomena, where the collapse of the alveolus is prevented by incentive spirometry. And initially, for specific, non-specific chest infection, you should not, always it is not pneumonia. There may be other infections too, due to plugging of the alveolus due to mucus. So first is atelectasis that can ultimately also can lead to acute lung injury. So you have to prevent it. First is pain relief. Number two, judicious fluid replacement. And number three, mobilization as early as possible.
Yes.
And good pain relief.
Yes.
So that patient takes deep breaths.
Yes.
Okay, now then patient had a established lung complication. How are you going to manage the situation? Patient has got respiratory distress, patient hypoxemia, and you have clinically evaluated the patient. There is less breath sound in the left lung base. And you have a clinically suspicion of patient having some lower level disease. What is the treatment for this particular situation?
Treatment involves early embolization.
So this is a patient who has got splenectomy in the first post-op day. What do you mean by early embolization? You cannot ask him to start working. He's having respiratory distress. So in that case, your prime aim is to what? To optimize the lung function. How to do that?
Sir,
hypoxia means you give oxygen.
Yes,
you can give high flow oxygen also.
Then, sir,
and then
we'll do the proper position of the patient.
Yes.
Then chest physiotherapy.
Yes.
Incentive spirometry.
Yes. The most important is having a good chest physiotherapy so that patient take deep breathing exercises, and this deep breathing exercise incentive spirometry can open up this adrenaline. And then most important thing is if we are not treating properly at this stage, this atelectasis may have super infection and patient may have pneumonia. Yes. Yeah. Now this patient is having fever. Apart from this respiratory distress, on second post-op day, patient is having fever. He is having cough with expectoration. Yes. So what might have gone wrong at this stage?
Sir, at this stage, sir, for early, sir, post-op fever, early development of post-op fever, sir, there might be the most common cause is, sir, atelectasis. development of pneumonia.
Yes. The patient who is having this continuation of this distress and then having purulent sputum and fever, you should always think that patient. And also you have to exclude other causes for fever. You see, second or third post-op fever means you have to exclude the other causes also. Agree. So how do you take care of patient having a established pneumonia?
So established pneumonia, sir, we'll start empirical antibiotics. And at the same time, sir, we'll give oxygen, and then, sir, incentive spirometry, chest physiotherapy. And, sir, so then, sir, fluid therapy will give. And, sir,
optimal fluid therapy. It's not that patient needs a lot of fluid. It's optimal fluid therapy. And then,
sir,
some patient might require if the patient cannot bring out the cough,
then, patient
they might need bronchoscopy aspiration.
Yes, sir.
Or lavage.
Yes, sir.
Laura, you can discuss other part. Other
Actually, you can have a chest X-ray done also in this point of time also, because the first post-operative fever is not always caused by any infection. Accordingly, first post-operative fever is a is a common, maybe a common phenomenon, but if it continues, what Sarah has told, that you should check for other things also.
Yes.
So, in upper abdomen surgery, if it is a fever, you can, though it is not very common, but you can check for the consciousness expectorant if there is expectoration. If it is expectoration, that causes sometimes infective. So first thing, yes, pneumonia is the first thing you should take in, but whether it is a viral or bacterial, that is another concern. In some patient is not properly coughing out, you can have a bronchoscopy done and can go for the assessment. But before that, after proper pain control, and you can also, if you are sure that it is not due to any other causes and the pneumonia is likely, you can also start with antibiotics of the chest, covering the chest infection in the second or third in the second postoperative day or third if the fever is not subsiding. So first of all, you should go give proper oxygenation. Next, you can also add some paracetamol and also the chest protective antibiotics like levofloxacin, etc. And you can also send the sputum for culture sensitivity. And also, if the patient is not expectorating well, then you can have a bronchoscopy done. And after that, if the saturation is not maintained, which is the main problem with COPD patients, they always have low saturation. That is in between 90 to 94 is normal. But if it is not maintaining in that level for a long period, and it is less than 80 or 85, sometimes it is prolonged, then you can also ask your anesthetist or your chest physician friend whether he or she is thinking of ventilation or invasive ventilation or not. Because in early ventilation also prevent more lung injury. So to prevent more lung injury, early ventilation is sometimes very beneficial.
And then on the background of these patients having a splenectomy, patient might have some intra-abdominal collection, sepsis, and then down the line between maybe third, fourth, or fifth, sixth day, patient may have respiratory distress. And this distress is not being corrected by even oxygen administration. So what might have developed by this time? Patient on the background of intra-abdominal collection, sepsis, on the background of COPD, and then hypoxemia not getting corrected. This can be a situation of ARDS.
Yes.
Okay, ARDS is a very serious complication. and what are the different features which will point towards a diagnosis of ARDS?
So reduce sound.
Yes.
Sir,
Respiratory distress, patient may have fever, and
then, sir, for an examination, sir, it reduced breath sound. So then, sir, aroused. So
yes.
then,
What are the typical X-ray appearance of patient having an ARDS?
Sir, homogeneous.
Described as infiltrates. Described as infiltrates. Okay.
Yes.
And if you do ABG analysis?
So on ABG analysis, then PaCO2, patient will be in respiratory acidosis. So with PaO2 and PaCO2 will be raised.
So what is the management in a situation when the patient develop ARDS?
Sir, ARDS patient can be managed, sir, as there's a collection of fluid in the alveoli, sir. So we have to decrease by giving furosemides. That's antibiotics.
The most important is maintenance of oxygen.
Yes, sir,
how to do that? Most of these patients will require ventilatory support.
Yes, sir. Sir, in if patient in ventilatory support, sir, then will increase the inspired oxygen level.
And you need a PEEP.
Yes, sir.
You need a PEEP, positive and expiratory pressure, so that this alveoli, which is collapsed, will get expanded.
Yes.
How will you diagnose in the post-op period the patient has developed pulmonary embolism?
We'll ask for the history, whether there is swelling, post-operative there is swelling of lower limb.
Yes, pulmonary embolism may happen on the background of patient have developing a deep vein thrombosis, number one. So to have an idea about whether the patient may develop deep vein thrombosis or not, there are some patients who are classed as high risk patient for deep vein thrombosis, number one. Patient having a pulmonary embolus may not have a manifested deep vein thrombosis. It can be a silent DVT leading to pulmonary embolism. So if it is an established DVT, what do you find? What may be the situation that you can diagnose, yes, this patient has got established deep vein thrombosis? What may be there in the clinical presentation? Patient will have swelling in the cuff. Patient may have swelling in the cuff. Patient may have fever. Patient may have fever. And then you can see that there may be appearance of acute varicosity in the leg. If you examine the patient, you can find patient may have tachycardia, which is out of proportion to the fever. You can demonstrate tenderness, and other sign you should not demonstrate. What investigation will point towards diagnosis that yes, patient has got a deep vein thrombosis?
Sir, we'll go for color Doppler studies.
Yes, Doppler study, which can show you the deep vein thrombosis. Can you tell me what are the findings in Doppler study which is pointing towards a deep vein thrombosis? You are doing a venous study with a venous Doppler. What are the features of deep vein thrombosis on this study? You place the probe over the deep vein and the leg. What is normal situation? If you place the probe, you can outline the vein, number one. If you apply color coding, you can see the blue dots are flowing across the vein, number one. You press the probe over the vein. What happens to the vein wall? Normal vein wall, this will collapse. If these two walls will meet, that means that the vein is compressible. Patient having a deep vein thrombosis, when you press with the probe, the wall will not collapse, number one. Second is, you ask the patient to get deep breath. inspire and expire, you are still with the probe over the vein. What change you will find in a normal patient and in a patient having a deep vein thrombosis? What will happen in a normal patient if you quit the probe over the vein? In the phase of respiration, what happens during inspiration? The flow will increase. And what in expiration? The flow will dampen. So this is described as phasic variation in the venous flow with the Doppler probe. This happens in normal person. If you place the probe in the vein, during inspiration, there is more flow in the vein. During expiration, then dampening of flow. But patient with deep vein thrombosis, when the vein is occluded by the thrombus, this phasic variation will be lost. Okay, you can demonstrate the echogenic thrombus inside the vein by Doppler study. Okay, once you diagnose this patient having a deep vein thrombosis, and on the background of this, now find patient having respiratory distress. What else may be there? If the patient has got a pulmonary embolism because of small embolus is going and getting dislodged in the pulmonary bed, apart from respiratory distress, what symptom patient may have? What happens because of this small thrombi? There is pulmonary infarction. There is pulmonary infarction. So apart from hypoxemia, respiratory distress, patient may have hemoptysis. Okay, so if you now suspect patient has got a pulmonary embolism on the background of deep vein thrombosis, what should be your steps?
So we'll start to
yes,
low molecular weight heparin.
Either low molecular heparin or you start the patient on unfractionated heparin. So patient should be going for a total anticoagulation. That is a prime treatment. Okay. How can you prevent this emboli coming to the lungs from the deep vein? Is there any measure that you can take? Yes, this patient having small emboli coming from the thrombus. How can you prevent that?
DVT stockings.
No, DVT stocking will not prevent this emboli getting dislodged and coming to the pulmonary bed. This is being done in the by interventional radiologists.
So we can put a filter.
Yes,
filter.
You can put a IVC filter. So you can go by interventional radiology either to the transjugular or transfemoral route, and you can put a filter in the IVC, which will filter the emboli coming from the lower limbs. Okay, Dr. Arko.
The prevention of DVT, though we do not recommend in a case of splenectomy patient that you should give immediately prophylactic DVT prophylaxis of DVT, that low molecular weight heparin you can give earlier if the patient is not ambulating, and also the stocking, which we usually do in a major abdominal surgery in the early post-op period. So these are the two things you can think of. But in case of emergency splenectomy, we rarely do this. That low molecular heparin and also the stockings, compression stockings, immediate post-op.
Dr. Arko, have you any presentation for 2-3 slides?
No, sir.
Okay. Okay.
The next thing I can ask you, if there is established pneumonia, if there is established pneumonia, in case of these patients, how will you proceed? It will reflect in 4.
So patient having established pneumonia, sir.
So you have a collapse along with somebody infection. Okay.
Yes,
so how do you take care of the situation?
Sir, we give supportive treatment with oxygen, sir. Oxygen. Then, sir, we'll start with antibiotics. Then optimal fluid therapy, sir. Then, sir.
How can you open up this block? There is might be an mucus plug, or there will be some secretions.
We can do bronchoscopy
First is intensive chest physiotherapy. Intensive spirometry, patient should deep breaths. Okay, patient should try to cough out. Then if this measure does not work, then you can consider doing a bronchoscopic aspiration and lavage.
So here also the steps. Number one, what I have told you that chest physiotherapy, and you can add pneumolyte. Now, once you are having pneumonia established, now there is a term called aggressive and aggressive fluid therapy, because there is a fluid loss. In these cases, you have to do aggressive fluid therapy, because that fluid therapy can also help in washing out the mucus. And then also proboscopic lavage and the antibiotic is come. So in this point of time, you can have aggressive fluid therapy apart from your pneumolytic and chest physiotherapy, so that mucus plaque can wash out. What has been recommended now.
Abraham sir, any question from your side? We are discussing the pulmonary complications in a patient having upper abdominal surgery.
Sir, I have heard the whole discussion from the very beginning. I have a different take. I mean, you have discussed everything that is post-operatively, but on the first day, I would like to address the problem in a different manner. Number one, the slide shows that the patient underwent splenectomy as an emergency for a abdominal trauma. And patient has got a PO, chronic COPD. These are the two informations I have got, and we are on the first day with a respiratory distress and hypoxemia. My take on this will be, normally in a trauma setting, we don't go ahead with a splenectomy unless and until it's a grade 4 or a grade 5 splenic trauma.
Yes. Yes.
So we have not got any information whether the splenic trauma was the laparotomy was for just a massive splenic trauma or a grade 4, grade 5 splenic trauma, or was it a splenectomy which was warranted due to something else and in the accident it has been removed? Because sometimes we open up the abdomen for a different reason and you find it's pain and let's take it out, that kind of a situation. That is possible. That's number one. Number two, if it is a grade 4 or 5 injury, I'm led to believe that there may be attendant thoracic trauma, and there is no mention about the thoracic trauma, whether it's fracture, no fracture, etc., etc. But the fact is that the patient has survived an anesthesia and extubated. So my take on this will be, number one, an acute exacerbation of the COPD. Number two, anything which happened during the surgery which has not been noticed by us. Number three, anything which has happened post-operatively. So my first thing will be to examine this patient, to see whether there is a bronchospasm acutely. Second, is there a pneumothorax, because the patient might have had a slow leak. Secondly, if the patient has got a central line, accidentally, whether it has come out, it is leaking, etc., etc. So as sir has said, the chest X-ray at that point of time would be a very useful investigation to find out what exactly has gone wrong at that point of time. The third would be related to the post-op situation, where, as you have rightly said, a very remote possibility of a deep vein thrombosis and pulmonary embolism, or even an MI, which we need to think, because it's a sudden onset of a problem where the patient has come out of anesthesia. These are my additional inputs onto this discussion. Thank you very much.
Yes, sir. Yes, sir. So the background was a blunt trauma abdomen with a grade 4 splenic injury, and then one of the important situation following upper surgery, particularly splenectomy, is having lung complications. So we are assuming that the patient has developed some lung on the background of COPD. Yes, we have already said that this respiratory distress in this patient may be because of acute exacerbation of the COPD, which was already there, and then newer onset of pulmonary complications.
Yes, sir.
So I think the student should take an approach that it's not necessary to come to a different diagnosis at the onset. The primary aim is management is to patient with hypoxemia, give the patient oxygen and see whether the patient is responding to the oxygen therapy, because it is said that prolonged hypoxemia in the postoperative is also a lung complication. There may not be collapse, there may not be pneumonia, but some patient may have prolonged hypoxemia. That is also described as a post-op lung complication. So administer oxygen and then examine the patient to exclude other causes like pneumothorax, like a pleural effusion. Patient may develop sympathetic pleural effusion following a splenectomy because you are working under the diaphragm. And there might be some post-op complications, like is known that patient may have diaphragmatic injury following splenectomy. So one should exclude other causes. So first thing is to think of common causes of pulmonary complications, number one. Number two, to understand whether the patient develops some other complications which needs a different form of treatment. Patient has got pneumothorax. So unless you diagnose pneumothorax, you cannot consider putting this patient on a chest tube. So that may be life-saving in this patient. And you should also think of other features. Patient having a pneumothorax will respiratory distress. Patient will have less movement of that particular side of the chest. The chest will be hyper-resonant. There will be absent breath sounds. And then do a chest X-ray. So the most important thing is taking a good history, doing a thorough assessment, and then coming to diagnosis and the therapy based on the diagnosis, as you discussed. If it is a atelectasis, you see, nothing very aggressive measures to be taken. The most important thing atelectasis is to prevent it, ask the patient to deep breaths, provide good pain relief, and then if the patient with atelectasis, mostly the treatment is conservative. And patient is not responding, patient is coming up with fever, patient having prolonged expectoration, that means patient is now going into phase of pneumonia. And there are some standard protocol for treatment of pneumonias. Okay, so the approach is important. In exam, you will have only 5 minutes or 10 minutes time for this scenario to be faced. So your approach should be correct. And then depending on the examiner's approach, you answer what should be the logical answer to the particular situation. Dr. Orko, anything to add?
Regarding what Dr. Abraham has said also, that what we have missed, one thing we should always keep in mind in a case of splenectomy, post-splenic injury, there may be a unnoticed diaphragmatic injury also. That thing also should be kept in mind.
Yeah.
And
it was a very good discussion. It was a very good discussion.
That's a generalized thing. Before in any type, this type A, what it is, ward rounds or case scenario, if the patient is there, you should spend few seconds or few minutes for going through a previous and present history and also the investigations which should be checked by you. Before going for answer in the case, you should do that, because it is a COPD patient, known COPD, so he or she might he should have some investigations done. He is an established COPD, so these things you should first look for. In any ward round case, you should spend at least 1 to 2 minutes in history and also the investigation.
Yeah, very right. So most of the time I find in the examination, students start answering, I'll do a chest X-ray, I'll do blood, I'll do ABG. Before you say the investigation, always keep in mind that every patient in the background ward round scenario needs a clinical evaluation, which will be history, relevant history, and a proper examination. These two are very important. Don't jump to investigation before you discuss the clinical evaluation. Okay. I think we have covered this most of the chest complication management. Okay.
Thank you, sir. Thank you.
Thank you. Thank you.